So we had a 36-year-old female referred in for refractive evaluation. She had been interested in options for several years. You can see right eye, left eye cyclo, pretty similar, no significant changes there. And pretty regular topographies when you look at Pennicams, pretty happy with that overall. Felt like she was a great LASIK candidate. Could have gone Evo, but she elected LASIK. So any thoughts on this? You've got packs, around 500, ACDs, a little over 3, patient personality, nervous energy, very nervous. Everything she did, she was kind of edgy about it in her responses. Nick, any thoughts on this case?
You could go either way. I mean, the chemistry is definitely thick enough. The cornea looked pretty regular. I don't see why LASIK is not an option or wouldn't be an option. Evo, you're right on the border, but you definitely could just based on her RX. You'd put in probably a -3 in both eyes.
Yep.
You could go either way. These are cases I usually leave it up to the patient. I talk to them about pros and cons for both, and what do you want?
Yeah, and that's exactly what we did. We left it up to her. She chose LASIK. Any other thoughts on this, Anu, Bobby?
These are the tricky ones because they can go either way. They'll do well with both. And so, I mean, unless you have a particular persuasive factor, they're just happy either way.
Yeah, I think for just like some people who don't see a lot of LASIK, I mean, like for me, I think like 2 standard deviations below that 535 or 555, whoever taught you, that pack value would be like 490 and below is what I consider a thin cornea. So I would say this is, I wouldn't classify this, maybe it's a thinner, but not necessarily a thin cornea, so much so that I'm saying, hey, you're not a LASIK candidate. There's no inferior steepening there. It looked like they were correctable to 20/20, so it looks like definitely could consider LASIK. And the anterior chamber depth has plenty of space. Anterior chamber depth, you want above 3.0, that's on label. 2.8 to 3, usually surgeons have some level of confidence there, just depending on your surgeon. And I think that, with regards to doing this, yeah, usually you just have the conversation with the patient, see which one they're leaning towards. And that's typically the one that we go with.
Yeah, absolutely. So ended up going with LASIK. So got her under the laser and she was so nervous. She couldn't fixate on the target on the right eye. So aborted. So went ahead and did LASIK on the left eye. She was able to fixate. She calmed down just a little bit. One day post-op, LASIK, left eye, 2015. She was thrilled. And she was like, I can't do it again though. I can't do it again. And the surgeon was like, there's no way I'm taking you to the laser again. And so we're like, okay, let's let your cornea recover and we'll plan to do an Evo. So we had her come back, monitor topography, everything was stable. 3 to 4 months later, when her refraction was stable, we went ahead and did Evo. She was really happy. She was thrilled. It was kind of interesting. So just again, when you look at those topographies, nothing irregular, nothing alarming. She would be a great candidate for either one. And she left us a really nice review. Ultimately, she was so funny. I asked her a month or two after surgery, I said, how was this experience for you? She's like, honestly, it's been amazing. I love my vision now. This is great. But if I could have done Evo for both of my eyes, it would have been an amazing experience. We ended up doing an IV sedation for her. She felt more comfortable being more relaxed. And that was one of the advantages in this patient of Evo versus LASIK is she can have a more controlled sedation and she didn't have any pressure. She didn't have to fixate on a target. So happy with those results, got a little bit creative with it, but ultimately got the patient to the end goal and she's thrilled with the results.
So the golden question here, is there any visual perceivable difference between the two eyes? Does she
So
have any?
I asked her that and I said, can you tell any difference between the two eyes? She's like, I really do feel like my right eye, just the quality, the clarity out of the Evo is a little bit better than LASIK. She's like, but it might just be because I've been happier with that experience. So refractively, numbers are spot on. Vision's great in both eyes. But she does feel like she sees a little bit better out of that right eye.
Nick, I think you bring up a good point though. Like you're not always successful when making a LASIK flap, and it's usually on the flap that you have the problem. It's not ever you're like at the eczema, you're like, oh, I can't do this. Usually, right? Like 99 times out of 100, it's on the femto. And I think that that's a really interesting question is when you're using the femto to make the flap. The question is at what point can you not make the flap, and what's already been done to the cornea? Because I think you have a couple options there. Number one, is you could just abort, then you could come back, after that eye has healed, maybe a week or 2 or 3 or even 4 weeks later, come back and try another LASIK flap, and you could try to make a shallower flap, or you could try to make a deeper flap. And I've seen that work, and I've seen it not work before. The other thing that you could do is just wait, let the eye heal, and then come back and do PRK on top, which would have been an option too, but obviously, that patient wouldn't have loved the recovery there. And then the third option here is going back and doing ICL. And I've seen that work a couple of times in these patients where they're real high nervous energy, where you come back and you're able to put an ICL in, and that gives them that quick visual recovery. They don't have to do the pain of PRK, and that works out really, really well. So on the question of when to do the PRK, I've seen PRK. We used to wait like 3 or 4 weeks, but if a LASIK flap is aborted, I've seen it done the same day, and these patients still have good results.
Nick asked about the visual quality. I'm curious about the halo effect from that kind of central aquaport. Did that patient notice a difference?
Nothing she was complaining about. I mean, and you'll hear other people talk about that. And so we try to prep patients. You're going to have some visual disturbance, maybe a halo at night that tends to neuroadapt over the course of 3 to 6 months after surgery. That's normal. That's just part of your eye adapting to the lens. And I never had anybody so bothered that they wanted the Evo explanted. Have you guys ever seen anything like that?
Not
No.
because of the vision. No,
Yeah.
I've seen one of the legacy, well, a couple of them, because we had a couple issues with pupillary block with the legacy ICL, not the Evo. The Evo, since that's introduction a couple years ago, has been just phenomenal safety wise. Bobby, I have a question for you, probably as the resident LASIK expert. Can you explain why we couldn't just do a little IV sedation and do LASIK on the other eye?
Yeah,
Or
that's a
could
good
you have?
question. Yeah, that's a really good question. I mean, really what it comes down to is like pupil tracking. And I mean, I don't know if you guys you probably have been in the OR plenty of times for cataract surgery, but sometimes you get these patients, you give them a little bit of Versed, and they just like fall asleep, they knock out. And this is especially difficult when you're trying to do the femto for cataract surgery. And you're like, Mrs. Jones, look down.